So I'm Tom Masterson. I'm a urologist over at the University of Miami. So just to give you a bit of my practice, since you've mentioned the words, anti-aging and performance enhancement, I do not do that. So my practice is really guideline based, focused on replacing testosterone when it is truly deficient. So I'm switching over to the Zoom here. I just to check, are you seeing the Zoom or are you seeing presenter mode? It looks like it's up. Yeah, you're muted, but
Yep, we can see it. We can
perfect.
see the full screen.
All right. So just to start here, I am not a cystic fibrosis expert. However, I am somebody who knows a little bit about testosterone replacement, as that is my practice. So if I say any things that, are potentially incorrect, offensive regarding cystic fibrosis, please correct me at the end, so that you can educate me. So this came off of one of the cystic fibrosis advocacy websites, and I think that there's an important really message here. Back in 2008, right, less than 20 years ago, the average age of a person dying with cystic fibrosis was 26. And now in 2022, the average age is 66. So, I mean, that is an incredible change in a short amount of time. If you talk to people who are in reproductive medicine and in urology, or really, I would say outside of the cystic fibrosis world, we considered this really like a pediatric disease, and we didn't worry about the things beyond that, right? But what's happening now is because people with cystic fibrosis are living longer, you are now starting to experience the same diseases of aging that everybody else is experiencing. Now, likely, there are going to be some differences because of how you got to age 66. However, we're probably now going to see more people with cystic fibrosis dying of cancers than we were of complications of lung disease. So we're here to talk about testosterone. So what exactly is testosterone? Testosterone is the sex steroid of men. It's derived from cholesterol, and it comes from two places. This is the testis, which is the majority of it, and then a small percentage also comes from the adrenal gland. Testosterone is important for male sexual organ development, especially during puberty. And then after puberty, it's really involved with bone growth and strength, libido, which is that desire for sexual intercourse, muscle growth, and then to an extent, sperm production. What I want to talk briefly about is the actual regulation of testosterone. So testosterone secreted from the testicle is stimulated by a hormone from the pituitary called LH. You can see this on the left-hand side of the diagram. The pituitary is actually stimulated by the hypothalamus through GnRH, and then there's a feedback loop. So just going through it, the hypothalamus is constantly regulating the testosterone levels throughout the body, then telling the pituitary to release LH to then stimulate the testicle, and then the testosterone that's produced feeds back on the hypothalamus, and that's what keeps everything sort of in homeostasis. The analogy that I try to use with patients is if you think of the hypothalamus as like a thermostat, and your testicle is the air conditioner. And the hypothalamus pituitary is sending the signal, basically the thermostat, to the air conditioner to tell it to do work. So what exactly is low testosterone? Well, the way it's defined is low testosterone is diagnosed when you have both symptoms as well as biochemically low testosterone. If you look at different guidelines, you may see different numbers, but generally accepted is a level of about 300. So if it's less than 300 consistently with symptoms, we consider that low testosterone. What are those symptoms? Well, this can include low sex drive, decreased energy, depressed mood, weight gain, decreased lean body mass, foggy memory. The takeaway from this is, unfortunately, the symptoms of low testosterone are often nonspecific and can be caused by other things like depression or sleep disturbances, problems with the pituitary, problems with the adrenal gland, and so forth. So it's important to get a full evaluation when you present with these symptoms. And I will say, don't blame it necessarily on testosterone right away until you've done a full workup. When we look at low testosterone, one of the first things we do is after we get the labs, right? Patient comes in, they're complaining of the symptoms. We check their testosterone and it's low, right? The first thing we do is we repeat it to see if it is real, okay? With that, we also look at a hormone called LH. That's the hormone again from the pituitary. If this is what's called primary hypogonadism, that is a problem with the testicle, right? The brain is working fine. It's just that the testicle is not working. So in that instance, testosterone is low and LH is high. Using our analogy with the thermostat is working. It is sending the signal to the air conditioner, but the air conditioner is not kicking on. Compare this to secondary hypogonadism. Here again, the testosterone is low, but in this case, the LH is low. So the brain is not sensing that the hormone level is low, so that it's not telling the testicle to do any work. In this instance, it would be like your thermostat is broken, but the air conditioner is working just fine. When patients present with that constellation, low testosterone with a low LH, we do additional workup and check things like prolactin, potentially get a brain MRI to look for small tumors, generally benign within the pituitary or hypothalamus, or we look for other causes like sleep apnea and order sleep studies, or if there's signs and symptoms of something like hemochromatosis, which is an iron overload disorder, we would order serum iron studies. And again, this is not a comprehensive list, but this is just to give you an idea. Because ultimately, when treatment, if there's something correctable, we try to correct the underlying cause of the low testosterone. So what are some of the causes? Well, we know that testosterone decreases with age. This is just an unfortunate reality. Testosterone decreases on average by about 1 to 2% every year after about age 40. Now, what we know is that people who have chronic disease, things like diabetes, obesity, high cholesterol, hypertension, smokers, alcoholics, people who use opioids, that decrease is much faster. So in men who are generally healthy, you would expect a slower decline in testosterone over time. In men with more comorbidities, it will drop more quickly. Now, there are also some genetic disorders that go along with low testosterone, and there's really nothing that they did. It's just their genes. And things like this are Kallman syndrome Kallman syndrome, Turner syndrome, Klinefelter syndrome. So those are again genetic disorders. So now let's look a little bit at the cystic fibrosis population. So low testosterone affects approximately 2 to 12% of men in the United States, and that's looking at everybody. And as we discussed before, testosterone does decrease with age. Now, interestingly, in the cystic fibrosis population, low testosterone is likely higher than the general population, maybe as high as 25 to 88%, depending on what sources you look at. And there may be some disease-related reasons to this. So cystic fibrosis, as you all know, is not simply a disease of the lungs. It is a systemic problem. And this can cause issues with the pancreas. This can cause malabsorptive disorders. In addition, the recurrent infections in the lungs. And all of those things may be contributing to the higher incidence of low testosterone. So again, malabsorption, if you're not getting the nutrients that you need, recurrent infection and exposure to various antibiotics, some of the side effects of specific antibiotics are decreased testosterone. If you're on steroids, right, glucocorticoids are a derivative of cholesterol. Cholesterol is also the base molecule or the base compound for testosterone production. So if you're getting excess glucocorticoid, you will actually have lower testosterone. There may be disruption in GnRH secretion, and then some of the newer medications that are currently used don't really get tested to look at necessarily how they impact hormones. Often drugs are tested for safety in pregnancy, but they don't necessarily look at either how it affects testosterone or sperm production. And again, what are some of those comorbidities associated with cystic fibrosis? Well, This is just a short list, but the ones that I think kind of stand out: cystic fibrosis related diabetes. We discussed beforehand that diabetes in and of itself can be a risk factor for low testosterone. Again, poor absorption of nutrients, especially the things that are fatty acid derived, vitamins A, D, and E. And then because you're not getting the absorption, you may be overeating with things that are or I should say more nutrient poor or less nutrient dense. And again, these can lead to kind of poor overall health. So there are benefits to testosterone replacement, and this includes improvements in erection quality, libido, that desire for sex. It can actually correct anemia. For those who have osteoporosis and osteopenia, it can improve bone mineral density. Again, improve lean body mass, specifically muscle mass, and actually help depressive symptoms. Not specific to this population, but in people who have a refractory depression, sometimes testosterone replacement can be helpful. All right, what treatments are available? Well, first and foremost, when we can, again, identify anything correctable, we try to correct it. And that may be lifestyle modification. For those with sleep apnea, that may be putting them on a CPAP or putting in a mouth guard. For those who have dysregulated sleep for other reasons because of their job, trying to adjust those things. Then the second thing is actually giving exogenous testosterone. And there are multiple ways we can replace this. This can be in the form of transdermal gels and patches, intranasal gel, intramuscular injections, subcutaneous pellets, and now more recently, oral pills. The goal with testosterone therapy is really to get the testosterone level back into normal range while simultaneously improving the symptoms. And I'll stress this because in my practice personally, I am more symptom focused than anything else. The guys who come in and say, "Doc, I need my testosterone in the thousands," I basically tell them to go to a different office. If they don't come in with symptoms, they should not really be getting treated. All right, what about side effects associated with testosterone therapy? Now, there are some delivery-specific side effects and problems, right? What I mean by that is, as an example, testosterone gels can sometimes cause a rash, and then you need to be careful as to who touches the gel. So if you put it on your arms and you hug somebody, that person is going to get a dose of testosterone. But common side effects to all of them: polycythemia, that's an increase in your red blood cell count; worsening of prostate-related lower urinary tract symptoms. So those who have like BPH, while controversial, increasing testosterone levels can slightly enlarge the prostate, leading to worsening symptoms. It can increase estrogen or estradiol. For some patients, it causes acne. And then big one, testosterone is a contraceptive for men. 60% of guys on testosterone therapy stop making sperm. What are more controversial side effects? Increased risk of cardiovascular events and possibly an increased risk of prostate cancer. When on testosterone therapy, there are things that we need to monitor. Testosterone is a controlled substance. So we as physicians are basically obligated to follow these things. So first and foremost, side effects, right? Like we listed before, the acne, the rashes, gynecomastia, which is breast tissue development, right? And then we look at testosterone levels. Why do I check them? I check them to see that you're actually biochemically responding, but I don't focus so much on the level to see whether or not, again, if we're getting into the thousands, things like that, if you go from the 200s into the 400s and you feel great, that's what we're going for. If you go from the 200s to the thousands and you still feel bad, then we need to look for other reasons for those symptoms. It's likely not testosterone that's the problem. Check the hematocrit, because again, that's side effect of polycythemia. Some of us believe that increased hematocrit may be the cause of increased cardiovascular events. We check PSA, especially if you're over 40 or have other risk factors, because if your PSA elevates and there's a risk of underlying prostate cancer, again, controversial, but we know that testosterone to some degree is used in prostate cancer growth. and potentially being on testosterone therapy with active prostate cancer may not be a good thing. And then we check your estradiol, especially if you're having some of those estrogenic side effects like gynecomastia. Now, I know you guys, I think, had another talk about infertility, but I bring this up because it may feed into some of the stigma or controversies with testosterone replacement in cystic fibrosis patients. So as we were kind of discussing, exogenous testosterone therapy is a contraceptive. Universally, men with cystic fibrosis are infertile due to the absence of the vas deferens. That's the tube that carries sperm out of the testicle, right? This is a form of what we call obstructive azoospermia. The sperm can't get out. There's another problem called non-obstructive azoospermia. This is where it's a production defect of sperm. And the incidence of non-obstructive azoospermia, the production defect, is really unknown in cystic fibrosis patients. So 1% of men do not make sperm. That probably means that at least 1% of patients with cystic fibrosis also do not make sperm, because again, cystic fibrosis is becoming a chronic disease, and we're likely going to see many other chronic problems show up now that patients with CF are living longer. So a problem here is that if you have a guy with CF who we know cannot get sperm into the ejaculate and we put him on testosterone, we're not really sure how that person is going to recover or what are the protocols to get sperm induction back. So it's something that we have to think about. And some of the issues that go along with this are the only way to get sperm from a cystic fibrosis patient, therefore, is a biopsy. And some research has actually shown that specific CF mutations, because now we know of thousands of them, may actually be involved in sperm production, and that may lower sperm quality to begin with. So as an example, Delta 508 may have some other effects on sperm production, because we know that when those patients, right, go undergo sperm extraction, they actually have lower sperm quality compared to other CFTR mutations. Hopefully that made sense. That was long-winded. So some retrospective studies have looked to see or have assessed testosterone screening in cystic fibrosis patients. And generally, the comparison group is patients with what's called congenital bilateral absence of the vas. Why? Because patients with CBAVD, congenital bilateral absence of the vas, do not have cystic fibrosis, but they are carriers of a CF mutation. So they're generally healthy, but they have this same infertility problem that patients with full-blown, two mutation CF have. So it's a good comparison group for many things. So in this study, they looked at men with cystic fibrosis and looked at their lab results to see how many of them were being screened for low T, and then how many of them were actually getting treated. And what they saw was that really the screening was not as robust as it was in these, quote, normal CBAVD patients. So I'm going to put this as a comparison. So this is this is the cystic fibrosis group. This was congenital bilateral absence of the vas. And I kind of put the final columns next to each other. And what I want you to see is that in this top part, right, hypogonadal men with CBAVD received a testosterone prescription about 78% of the time, compared to men with CF who had low testosterone were only getting prescriptions about 60% of the time. So much lower rates. And you can't really go back into these databases to get the granularity to say, well, why is that happening? This is just looking at populations and seeing what is happening. Now, there's some other specific things that I think are important to look at in cystic fibrosis patients, which is solid organ transplants and testosterone therapy. So a couple different studies, and again, it's a little bit difficult to parse out because there's not a lot of research in this area looking specifically at CF. So you kind of were getting grouped into patients who are getting other transplants like liver, kidney, pancreas. And this was a retrospective database looking at patients who were specifically undergoing lung transplant, but they didn't specify why. And they looked at testosterone levels before and after transplantation, right? Interesting study because in other populations, kidney transplants, we know that testosterone levels improve after kidney transplantation. Now, this study actually did not show any difference before and after. But interestingly, and that was looking at average testosterone level, when you kind of broke it down to how many people had normal testosterone levels before versus after, 26% of people had normal testosterone levels before transplant. And then afterwards, there was 30 patients. So 4 patients actually moved up into normal testosterone levels. And the only intervention really was a transplant. Keep in mind, this study, though, was not specific to CF patients. I actually did reach out to the senior author on this paper to see if they were able to have that granularity, and basically told me that they were not able to look back and see if there were specific CF lung transplants. All right, what about testosterone therapy in general for patients receiving a solid organ transplant? So again, this was a retrospective paper. Again, same author on this one as well. This was 87 patients with low testosterone who had received a transplant. 58 patients received testosterone therapy. 29 patients did not. And all of these men, or all of these patients, men and women, had, or men, I guess in this case, but had low testosterone beforehand. And you can see these Kaplan-Meier curves here to the right, that the people who had testosterone replaced actually had greater survival than the patients who did it. So just to say that again, the men who had low testosterone, who received an organ transplant with testosterone replacement, survived longer than the men who did not receive testosterone. And then they also looked at adverse events in those patient population groups between, again, those who didn't receive replacement and those who did. And again, there was really no difference in other adverse events. There was no difference in prostate cancer. There was really no big changes in hematocrit, no difference in organ rejection, right? This was just longevity. So with that, we'll kind of summarize this relatively quick talk. But low testosterone is likely as or more prevalent in CF patients for a variety of reasons. Testosterone can improve the quality and quantity of life, and there are some special considerations, as we discussed, for patients who have fertility concern. And then testosterone replacement may actually improve the outcomes of solid organ transplantation. So certainly in your patient population, cystic fibrosis patients, there's likely a lot more research required to see what's going on as you guys are living longer and likely to experience this more frequently.